Good evening, welcome. I'm Daniel Southern, and I want to thank you all for joining me on such a frigid night in the Northeast. We're going to be talking about alternatives to surgery tonight. We're going to talk about a new field of medicine known as regenerative orthopedics. I'll explain what that is, explain what it is exactly we're doing, discuss a few examples, and then briefly discuss some of the literature and some specific joints of the body that we treat. And then end with a brief word of caution. I'll be moving quickly because there's a lot of material here I'm trying to get through, and I'm happy to spend as much time as anybody likes at the end of the presentation to answer questions. Just a quick word about myself. I graduated medicine at the State University of New York Health Science Center at Brooklyn, otherwise known as Downstate Medical Center, which is famous in medicine for pioneering the use of MRI and discovering the medication sildenafil, otherwise known as Viagra. I then did my fellowship in spine and sports medicine at the Hospital for Special Surgery, and I've been a practicing physician since 2004 in the Connecticut area. We are going to talk tonight about sports injuries and arthritis and how to avoid surgery and alternatives to surgery. In 2005, for the first time on Earth, medical doctors began treating orthopedic conditions using precise stem cell injections. And this started a new field of medicine known as interventional orthopedics. What is interventional orthopedics? Well, the best way to describe that is by discussing traditional orthopedics. What is traditional orthopedics? Well, in traditional orthopedics, they're using lots of tools: scalpels, drills, hammers, saws. And what they're doing is they're cutting, grinding, pounding, hammering, amputating. They're using a lot of hardware as well. They're placing screws, plates, rods, nails, anchors, staples, and sutures. The metaphor here is one of carpentry. Compare that to interventional regenerative orthopedics. We are using only needles and very advanced imaging. And this is non-radiating imaging. It is ultrasound primarily, and some radiating imaging, fluoroscope, which is a real-time X-ray. What we're doing is we're injecting. What are we injecting? We're injecting our patient's own blood and or cells. We're delivering growth factors to damaged tissues in the body. The metaphor here is one of gardening. In traditional orthopedics, they are removing tissue, they're rearranging tissue, they're deconstructing, reconstructing. Ultimately, they're replacing native structures in the body. As opposed to interventional regenerative orthopedics, where we're attempting to stimulate repair and regrowth of tissue. We are preserving native structures. That's the very basis of what we do. And this is very, very key. Why is that? Because the design of the human body has been refined for many thousands of years. And when you alter the design of the human body, whatever good you may have done, the alteration comes at a cost. So whatever you give, you're taking away. And that's a very, very important concept. And interventional orthopedics attempts to preserve native structures without altering them. And that's an important concept. So let's talk about the traditional orthopedic algorithm of treatment of a painful joint. A joint that may have been acutely injured, or a joint that's becoming arthritic, or both. It starts with an injury. And when we say injury, we're not just talking about stepping off a curb awkwardly or falling down a flight of stairs. We're also talking about surgery, because surgery is a form of controlled injury. So it starts with an injury, and most injuries will respond to acute triage, and that's a fancy word for a little bit of relative rest, ice, ibuprofen. In a couple of days, you're as good as new and you're ready to go. If that's not the case, you go to your primary care physician and he says, well, let's do some rehab, and he sends you to physical therapy. Most of the rest of these injuries will respond to physical therapy, and that's that. But if you're still not better and you come back to your primary care doc, he probably sends you to his colleague, the orthopedic surgeon, and the orthopedic surgeon looks at you and says, hey, let's try a steroid injection. This works a lot of the time. And you get a steroid injection. And, you know, if that solves the problem, great. But quite often it solves the problem only on a short-term basis, couple days, couple weeks, you know, couple months maybe. But then you're back in the orthopedics office saying, you know, doc, it worked great, but now it's bothering me again. And the orthopedic is going to tell you, well, it's time to get an MRI. Well, if you get an MRI and you're standing in an orthopedic surgeon's office, your chance of getting surgery goes up 90%. So let's say you have a surgery, and whether it works or not or doesn't, you know, you re-injure it, or a couple of years go by and it starts to bother you again. You go back to the surgeon and you have another surgery. More time goes by. This time when you return to the orthopedic saying that knee still bugs me, he looks at it and he says, well, time to replace that joint. This is the traditional algorithm of treatment in orthopedics today. Well, what's wrong with this algorithm? Well, a few things. Let's start with steroid injections. What's wrong with steroid injections? Well, steroids are toxic. They kill the very cells in any joint that's painful that we are trying to keep healthy. Steroids kills them. This is a study that was done in 2017 in the Journal of American Medical Association. They injected triamcinolone acetate, which is a steroid, at a standard dose of 40 milligrams into knee joints. And they did it every 3 months for 2 years. And they compared that group to another group that received normal saline, basically salty water injections into their knees every 3 months for 2 years. They got MRIs at the end of 2 years, and what do you think they found? The patients that had gotten triamcinolone acetate, a steroid, injected into their knee every 3 months for 2 years, had a 50% loss of articular cartilage in their knee. Steroids are toxic. They are terrible. They weaken ligaments, they lower bone density, they raise blood sugar, they suppress the immune system, they suppress the adrenocortical axis in the body, causing weakness, fatigue, and depression, and even sometimes psychosis. The cane anesthetics that we often inject along with steroids when we're injecting a joint in the body, such as bupivacaine and lidocaine, are, if anything, even more toxic than steroids. Lidocaine kills 90% of chondrocytes at 1 hour of exposure. This is a study published in 2011. So steroid injections are a bad idea. Now, in my office, if you've never had a steroid injection, because it's such a standard form of treatment, and it's done in every orthopedic office in the country, I will do 1 steroid injection in your joint. I will do only 1. You're entitled to 1, but I won't do more than 1 because I know how bad they are. So what's wrong with the current algorithm? Meniscectomy. This is otherwise known as the let's clean up the arthritis surgery. And this is a picture of a knee arthroscopy. Well, what's wrong with it? Well, a meniscectomy means that they are cutting out some of the meniscus, and the meniscus are large chunks of cartilage on either side of the knee joint that cushion the loading forces of the knee. And orthopedic surgeons are absolutely obsessed with tears in the meniscus because it allows them to do this surgery right here that you're looking at. And there's nothing about repair going on here. What they do is they remove cartilage of the meniscus, the big hunks of cartilage. They remove as much meniscus as they need to make the tear no longer visible. Well, this is a very bad idea. Why? Because people who undergo this surgery are at an increased risk for osteoarthritis 3 times the normal rate 8 years after surgery. And why does that happen, do you think? Well, it happens because they're taking out these large cartilage cushions in the knee. And what that does is it increases joint loading forces. And if you do that over time, thousands of loads and unloads in the knee, what happens is you accelerate degeneration and the joint begins to break down and you have the early appearance of osteoarthritis. There's only one proper indication for meniscectomy left, and that's if you tear this big hunk of cartilage so badly that there is a flap of meniscus that's getting caught between the two articular surfaces of the bones of the knee, and the knee locks temporarily, and you got to shake it and wiggle it around to get it to unlock. Then we have to go in and cut out that flap. But short of that, this surgery should not be done. What's wrong with the current algorithm? Knee ligament repair. And what we're talking about here and what we're showing you here is a traditional anterior cruciate ligament repair. And this is the repair right here. And this is a surgery that orthopedic surgeons are rightfully very proud of, because you cannot play sports without an intact anterior cruciate ligament in your knee. And orthopedics are able to get professional athletes back on the field of play by doing this surgery. But we've been doing it now for 2 decades, and we discovered that there is a problem with it. And we're not sure exactly why there is a problem with it, but the theory is that the angle of repair is steeper than the native angle of the native ligament. This is the repaired ligament angle, and that's because they got to put a screw, which you can see right here in the back of the thigh bone, and a screw in the front of the leg bone to anchor this repaired ligament, which they're getting either from a dead man or harvested from a place like your quadricep tendon up here. The native ligament is at a much shallower angle, and we think that causes a rotational instability over time after ACL repair, which results in early onset osteoarthritis. This is an article from the New York Times in 2017, quoting a pediatric surgeon from Boston's Children's Hospital, Meninder Coker. He reported that the rate of ACL repair in adolescents was soaring. There was a 5-time increase from 2004 to 2017. And what they had noticed was that 50% of these young athletes were developing osteoarthritis 10 years after their surgical repair. Think about that. You've got a 15, 16-year-old athlete, tears his ACL, you repair it. At the age of 25 or 26, if he's one of the 50% of the unlucky cadre, he will have knee arthritis at 25, 26 years of age. What are you going to do then? Even a best knee replacement lasts only 25 years. So the article ended by saying, will surgical techniques that more closely resemble the native anatomy reduce risk? Absolutely. That's the answer there. Absolutely, they will. What's wrong with the current algorithm? Joint replacement. Joint replacement is also soaring. Like I mentioned, or I should mention, when I was a fellow back in 2004, we wouldn't think of replacing your joint if you were anywhere below 55. And now, 20 years down the road, we're replacing joints in 45-year-olds. So the incidence of joint replacement is increasing dramatically. How well does it work? Well, it doesn't work very well. Harding published a study in 2014 showing that only 1 in 20 people with knee joint replacements achieve normal activity levels. And Metzna in 2014 published a study showing that anywhere from 44 to 52% of patients have the same pain they went into the procedure with 3 to 5 years following joint replacement. 87% of patients will develop knee pain after total joint replacement, according to the same study. So, in other words, a lot of joint replacement doesn't work out very well, particularly knee joint replacement. And then over time, we're talking years and years, you have the risk of metal and material fragmentation from the orthotic that's placed inside, the prosthetic that's placed inside the knee. It wears down. You can get high levels, toxic levels of chromium and cobalt, which is a bad situation. So what is the promise of interventional orthopedics? Well, the promise here is that what we're doing is we're using the body's ability to heal itself. And the theoretical appeal of that is tremendous. All we're doing is harvesting repair cells in our patients, concentrating them and placing them very precisely at areas of injury, and then getting out of the way and letting the body take care of this. So it's minimally invasive. All we're doing is using needles and injecting cells. This leads to a minimal post-procedure recovery and a less painful rehab. It dramatically reduces the risk of the procedure. It's nowhere near the risk of any type of even minimally invasive surgery. And when we're successful, we preserve native tissues, and there is no need to alter or replicate nature's design. And that is key. There's that concept again. Here's a cartoon now of the healthy balancing act inside any joint. You may be aware that bone and cartilage remodels itself over time. So in every healthy joint, there's a controlled breakdown of bone and cartilage as well as a buildup. So you've got catabolic forces. Catabolic is a fancy word for breaking down, balanced by anabolic forces, which is a fancy word for building up. And in healthy joints, this is a balanced process, so that you're constantly repairing injured cartilage and repairing bone that needs repairing and replacing. In a joint that becomes painful, the forces that are breaking the joint down become predominant. And what are some of the things that'll do that? Well, injury will do that. And remember, surgery is a form of controlled injury. And any type of injury to a joint can accelerate degenerative forces in that joint, particularly if it contributes to instability in that joint, meaning that the joint is slipping a little too much. After they take out some of the meniscus, the joint just doesn't seat the same way as it once did, and it's clicking and shifting very slightly over time. And when you multiply that by millions of times, you're talking about destroying a joint. What else does this? Obesity, being overweight. Why? Because carrying extra pounds increases loading forces in the joints of the lower extremities of the body, and this too can accelerate degenerative change in those joints. Smoking, add to all the terrible things that smoking can do to your heart and lungs, the fact that smoking will absolutely destroy the joints of your body. Smoking produces oxygen radicals, which work like wrecking balls through healthy cartilage. Poor diets lead to chronic inflammation in the body, and chronic inflammation is the bad form of inflammation, and it not only destroys your joint, it will eventually kill you. Poor fitness levels also contribute to chronic inflammation. They reduce the nutritional access of the cells that live inside your cartilage, and sedentary lifestyles do the same thing. All of these can increase the forces that degrade the joint and tip this seesaw towards the side of the balancing bar that says the joint is really starting to hurt me now. So how do we counteract the forces that break down the joint? Well, we focus on forces that are anti-catabolic, that work against breakdown. And what are those? Well, only within the past decade, a little more than a decade, have we discovered that human blood, specifically the serum portion of human blood, contains chemicals that inhibit the enzymes that break down bone and cartilage in a joint. And in a painful joint, a joint that's inflamed, or in an arthritic joint, what's happening is these enzymes are out of control and they're digesting your cartilage. And just injecting human serum into that joint, we immediately change the chemical microenvironment. Why? Because that serum contains chemicals that inhibit these enzymes that are eating your cartilage alive. Some of these names are interleukin receptor antagonist protein, known as IRAP, alpha-2 macroglobulin, known as A2M, TIMP, also known as tissue inhibitor of metalloproteinases, one of these enzymes that are digesting your joint. So injecting blood into a joint, and we're talking the serum portion of your blood, because you don't want to inject red blood cells. Red blood cells are going to absolutely destroy your joint. Ask any hemophiliac. But the serum portion of your blood, it's a very smart thing to do in a painful joint. What are some of the other forces that work against joint breakdown? Well, anabolic forces. Forces, again, anabolic is a word that means build up. So what are these forces? Well, in a word, growth hormones. These are powerful cell signaling molecules. They promote cell division growth. They increase the vasculature, which is very important because they provide greater blood flow to damaged tissues. They stimulate protein and matrix secretion. What are some of these growth hormones in the human body? Well, here are a few names. PDGF, platelet-derived growth factor, fibroblast growth factor, vascular endothelial growth factor, VEGF. Where do we get these factors? Well, we get them from our patients, and we call them orthobiologics. And that term comes from using our patient's biological tissue to treat orthopedic conditions. So we call the term orthobiologics. And we get them from our patients who are sitting alive right in front of us. We call them autologous repair tissues. Autologous is a fancy word for self. All we're doing as physicians is we're manipulating these repair tissues for treating musculoskeletal injuries, joint pain, ligament tears, tendon tears, arthritis, early and late, broken bones that don't heal, on and on. Repair tissues in the human body come in two flavors. One is a small circulating blood cell known as a platelet, so you may have heard of platelet-rich plasma. And the other is an adult stem cell. Now, 30 years ago, we didn't even know that adult human beings had stem cells in their body, and it turns out they do in every niche of their body. And the stem cells that we're talking about using come from bone marrow. In my clinic, that's all the stem cells that we use. They come from bone marrow. Let's go back to this schematic about the balancing act in a joint now, and I'll explain to you what we're doing. Let's say you walk into my office and you have pain on the inside of your knee after slipping off a wet curb and landing awkwardly on the street. And I work you up and I diagnose. I say, well, you know what you did is you strained your medial collateral ligament in the knee. You didn't tear it. You strained it. It's painful. It's going to take a long time to repair, but we can speed up that repair process by injecting it with a little blood. Or conversely, you come in and you're 55, you're an aging warrior, and you go, man, my knee has been killing me and it just won't stop. What's going on, doc? And I take a look and I say, well, hey, guess what? You got early arthritis. But for both of these conditions, I would say to you, look, why don't we try a platelet-rich plasma injection? So let's say we do a PRP injection. What are we doing exactly when we're doing that? Well, when I inject platelet-rich plasma into your knee joint, I'm injecting a whole host of anti-catabolic factors that we just discussed. Alpha-2 macroglobulin, IRAP, interleukin receptor antagonist protein, TGF, tumor growth factor beta, TIMP, tissue inhibitor of metalloproteinases. And I'm immediately changing the chemical microenvironment and turning it into a healthy pro-growth environment inside that painful joint of yours. At the same time, with PRP, we are getting powerful growth hormones, one of which is platelet-derived growth factor. So that's a pretty good mix, and quite often we can solve your issue with just injection of some platelets into your knee joint. But let's say you've torn your ACL. You've actually torn it. Let's say you come in with more than early arthritis. It's pretty bad and the bone is now involved. I'm going to probably say to you, hey, you know what? This is a stem cell procedure. We got to go get some bone marrow from you. So we're going to do a bone marrow stem cell procedure, BMSC. What do we get when we inject bone marrow into the any joint of the body? Well, we get a powerful mix of anabolic growth hormones, a whole bunch of them. And what we do when we inject PRP and or bone marrow, we are putting our finger on the scale and we're tipping it back towards a repaired joint, a healthier joint, without doing surgery on it. Let's go back to the traditional algorithm that we discussed earlier. What happens in my office? Well, it's pretty much the same up until the MRI. If we get an MRI and I see that you've got a ligament tear or a meniscal tear or a shoulder rotator cuff tear, I'm not going to say, let's go to surgery. I'm going to tell you, let's do a regenerative orthopedic injection. Let's say we do that. I'll send you back to physical therapy. 8 to 12 weeks later, you're singing my praises because you have no more pain and your joint is functional again. You're happy. And what we have done is we have preserved your native tissue. And more importantly, we've taken you out of the algorithm that pushes you towards joint replacement. And trust me, that's a wonderful thing. What can we treat? Well, we treat all kinds of things in my clinic. We treat headaches, we treat neck pain, we treat upper back pain, we treat shoulder pain, shoulder arthritis, rotator cuff tears, shoulder labral tears. We treat wrist arthritis, thumb arthritis, elbow arthritis. We treat low back pain. Every day of the week, we treat low back pain. We treat sciatica, which is that horrible radiating leg pain. We treat disc bulges and herniations, and we treat lumbar spinal stenosis. We treat hip arthritis and hip labral tears. We treat knee arthritis, meniscal tears, ACL tears, MCL tears. We treat ankle arthritis, ligament and tendon tears. Here are some examples of interventional orthopedics. This is a picture on the left here. It's a standard setup in my clinic. This thing is a C-arm fluoroscope, and it's taking this picture that you see right here of this patient's knee. This is a knee peeking out of fully sterile drapes. This is the MRI of that same knee. And what it's showing us is the kneecap and then the distal thigh bone, which it's articulating with. And the MRI also shows us the cartilage, which is this gray line here. And if you look closely, you can see that that gray is not smooth. It's fissured and broken up. And it's fissured and broken up, and what's happening is some of this white, what's white on the MRI here is fluid, is being forced, this fluid is being forced into the bone, and the bone now has edema and what we call a bone lesion. That's what this bright white signal inside the kneecap is. Well, this means the bone is going to die eventually, and it's got to be treated. So this is early arthritis in this knee joint. So we've got to treat the cartilage and we've got to treat the bone, and that's what this picture here shows that we're doing. We've got a trocar going into the kneecap. A trocar is a fancy name for a very heavy gauge needle. And we're injecting bone marrow that we're getting from the hip bones into the kneecap, right in this area of increased signal. This is a needle injected behind the kneecap. This dark streak is some contrast dye that's being injected, showing the operator where the cells will flow when he injects the cells. And then we're injecting stem cells over the cartilage at the back of the kneecap. This is a real-time fluoroscope view of two placements of a needle treating a shoulder. And this is a shoulder labral tear. The first placement is into the shoulder joint itself. This long streak of dark dye is in between the glenohumeral joint, and that's the shoulder joint proper. The second placement is highlighting this little triangle of dark tissue. That's the labrum. So this is how precise these injections can be. This is the hydrodissection of the median nerve at the wrist. The median nerve is the nerve that is being pinched when you have carpal tunnel syndrome. And here comes the needle right around the median nerve, and we're injecting platelets around the median nerve here. This is the size of a pea. This shows you how delicate and how tiny these procedures can be. So very precise injections. Now, why will interventional orthopedics replace elective orthopedic surgery? Well, in many cases, it already is. Why is that? Well, because number one, it's less invasive, which means there's less risk involved. There's a quicker recovery. It doesn't take a full 12 months to achieve a new baseline after we treat a joint. And when we're successful, we're preserving your native tissues. And again, there's that concept. It's much better to hang on to the native tissue than to replace it. Much better, always. So let's take a 30,000-foot view of what we're doing. We're able to help many patients with severe shoulder arthritis, avoid a joint replacement, or rotator cuffs and labral tears, avoiding surgical repair. Rotator cuff. What's the problem with rotator cuff surgery? Well, every surgeon knows that rotator cuff repair can re-tear. And when it re-tears, it just ruins the success of the repair, and it throws out the window all the agony you went through with the surgery to have it done in the first place. Henry did a study in 2015 showing that Of 954 patients over 18 studies, the re-tear rate was almost 80%. Think of that. That's 8 out of 10 patients who had a rotator cuff repair anywhere from 3 to 5 years after that repair have had a re-tear. So the question is, why'd you do it in the first place? And the rate of re-tear occurs with the size of the tear and with the age of the patient. So that's the problem with rotator cuff tear repair. So what do? Instead of surgery, we inject high-dose stem cells precisely into the tears using ultrasound guidance. And this is a cartoon showing exactly what that looks like. This is a transducer, ultrasound. It's bouncing sound waves off the rotator cuff so the operator can see it. And this is the needle going right into the rotator cuff. There was a randomized clinical trial just completed in 2024 showing how successful this is. This was a small study, 49 patients, about 50 patients. And these were non-retracted tears, meaning the tears were complete, but they were not retracted. In other words, the ends weren't pulled apart more than 1 centimeter. And patients were followed for up to 2 years. The re-tear rate after injecting stem cells into the rotator cuff tear, 6% compared to 80% that I just showed you. This is a graph of the outcomes. The people who had stem cells injected into the rotator cuff were compared to those who torn their rotator cuffs and decided to do just physical therapy. And this is the outcome score called a DASH score. The higher the score, the greater the disability. So both wings of the study started out pretty much the same place. And after a month, they were kind of in the same place with some minimal improvement. Another 3 months later, the people doing physical therapy were actually just a little bit worse. 6 months after that, they were not much better than where they started after physical therapy. Compare that to the folks who got stem cells. 1 month out, they're minimally better, but look at 3 months out, they're dramatically better. Look at 1 year out, they're very significantly better. And that's the promise of stem cells. Here is a full thickness rotator cuff tear that is retracted. And remember, this was not a patient that was in the study. This is a retracted tear. And this is about 1 centimeter. So this is absolutely the limit at which we can treat with stem cells. This picture was taken in January of 2011. This is a follow-up 10 months later. This patient had not 1 stem cell procedure, they had 2. And that's a point I'd also like to make. We all want it to be one and done. And often it can be. But often, too, it takes more than just 1 treatment. So this patient had 2, and 10 months later, this is what the MRI showed. There was a connection between the 2 ends. It's not a fully mature ligament yet, or tendon yet, rather, because more time is needed for that, but it's connected. It's reconnected at this point. So that's a dramatic before and after. We don't always see dramatic before and afters, but that's one that we just had to show you because it was pretty dramatic. We're able to help many patients with ACL tears, other knee or joint ligament tears. This is a knee ACL tear avoiding ACL replacement. These are the types of ACL tears we can treat. We can treat partial, full thickness non-retracted. We can treat full thickness retracted tears if they're not retracted more than 1 centimeter. That's our cutoff at that point. This is just a couple of pictures showing how this procedure is performed. This is a pilot study that Centeno did in 2015 showing that, hey, actually this does work. This is a larger fluoroscope view of a knee. This is the kneecap. This is the thigh bones, the leg bone. This is a needle coming into the front, injecting dye into the ACL, which is lighting up here with a dark contrast dye. This is how it's done. This is a fully torn ACL. And it had a lot of gray in it. This is a graph of the gray scale. This is after injection of stem cells with a fully remodeled ligament. Very little gray. Graph shows very little gray. Fully repaired. This is a study that was done from registry data. This was not a randomized clinical trial. So this is like level 2 evidence. Showing that there were improvements. 77% of 29 patients objectively improved 8 months after the procedure with MRI evidence of increased ligament density and repair. 72% of patients were improved 2 years after doing this. 5 of them went on to have surgery. 1 had a re-tear. So let's consider 6 of them failure. That's a failure rate of 20%. And this is compared to failure rates in ACL repairs, re-tears of up to 29%. So, somewhat equivalent, but probably on the balance, avoiding surgery and having stem cells injected into a torn ACL, much more preferable than having the surgery itself. A final picture of a torn ACL, lots of gray, kind of balloon, amorphous, after repair with stem cells, fully reformed. Avoiding knee surgery. This is a study Centeno again did in 2018, 2-year comparing bone marrow and platelets to exercise. Of course, the patients who got bone marrow and platelets were better at all time points compared to the patients who just had physical therapy. And at 3 months, all the patients who were in the physical therapy wing were allowed to cross over. They all did so, and the majority of them were happy campers at the end. Knee arthritis, avoiding knee replacement. This is one of the landmark studies in the field. It only came out in 2021. It was done by Ernigau, who's one of the godfathers of this field. He is a French orthopedic surgeon, and this is the type of study that can only be done by a national government. He had 140 patients in this study. They had bilateral knee arthritis to the point where he replaced one of the knees, and in the other knee, he injected that knee with bone marrow stem cells from that patient. And then he followed them for 15 years. This is unheard of. Nobody does studies like this. This is an outrageously expensive study. French national government did it for Ernigau. What did they show? The bone marrow injection arm, the bone marrow injection knee, 18% of them, 25 out of 140, went on to have a total joint replacement. So these are considered failures. What was the failure rate? 1.19% per year with just an injection of bone marrow into that arthritic knee. The other knee, which was replaced, 15% of them failed. 21 had a revision. They had to revise the original joint replacement. And the incidence of failure here was 1%. 1% versus 1.2%, roughly equivalent. The conclusion, this study showed that orthobiologic injection using BMAC had a sufficient effect on pain to postpone or avoid total joint replacement. I'd just like to finish up tonight, and you've been very patient, and I appreciate that, by saying just a couple of words about stem cell hype. You've only been doing this for about 20 years in medicine. That's a blink of an eye in a very conservative field. Predominantly, this remains a cash on the barrelhead procedure. And what that means is there is a lot of hype and a lot of fraud involved. A lot of people have jumped into this space and are doing stem cell injections, not using your stem cells because they claim that they've got better stem cells than yours. That's a false claim. It's fraud. It's not true. But what you need to understand about a new treatment, such as stem cells, is it goes through 3 phases of procedural adoption. And the first phase is, man, this is magic. It helps everybody. And that's what it seems like when you first start out. But you do it in a few more patients, and maturity sets in, and you say, well, hey, this is great. And it helps almost everybody. You do it for a few more years, and you arrive at this point. Hey, let's figure out who's a good candidate for this modality. And that is exactly what happens in my office. We have candidacy grades, and they're based on a bunch of criteria. What we find on exam, what we see on your MRI. It is my pleasure as your physician, when you come to see me, to give you an honest opinion as to whether you're a good candidate or not. I am one of the few physicians in this country, and there's only an outside limit of maybe 300-400 physicians who are dedicated to bringing this field into the mainstream. Therefore, I have no interest in injecting a knee joint or any joint in the body in someone I know is not a good candidate who will not do well. So I will give you an honest opinion. And I will give you that honest opinion because I do know that a lot of you will say to me, I don't care. I want to try this. And I do a lecture where I discuss every joint in the body, and I discuss one case where I told the patient they were a poor candidate, they shouldn't do this, they should probably have the joint replaced or surgically repaired. They didn't do it. I did stem cell in them, and they had a success. So these are the exceptions to the general rules. And maybe sometime soon I'll deliver that discussion. But the thought I want to leave you with is that my clinic is among very, very few clinics in the country that's in phase 3. Everybody else in this space is still pretending that what we're doing is magic. It's not magic, it's medicine. And I hope that I have impressed that fact upon you tonight, if I have done nothing else. Thank you so much. I'll be happy to take any questions from anybody who's still with us. I got a question here now from an anonymous attendee. Please comment on AVN treatment. Thank you. Yes, AVN treatment. AVN stands for avascular necrosis. We can treat the first 2 grades of, the first 3 grades actually, depending, of avascular necrosis. In other words, if you come in before the bone begins to collapse in avascular necrosis, I can probably help. You have to be aggressive. You have to go right into the area of AVN with bone marrow, but you can turn it around. I've had successes of doing this. The problem is that most people get symptomatic at the point where they're just past what we can do to help you. And they come in and we see the joint is beginning to collapse. And at that point, it's just like, you got to have the joint replaced. Unfortunately, when you're ready and the joint is telling you that it just can't move anymore. But yeah, we treat early forms of AVN. When we catch them, absolutely. We treat them with bone marrow very aggressively. Let's see what else we've got here. Does insurance typically cover this? As I mentioned earlier, this is sort of the Wild West of stem cells. And there's lots of people who are doing fraudulent work in this space, who are charging the moon for this. The short answer is no, insurances don't cover this. All the major insurances are still on the sidelines, waiting for the data to come in. When in fact, the data is coming in. It's been coming in for the past 10 years, and it's accelerating more and more. I believe, of course, I'm drinking the Kool-Aid. I firmly believe that all commercial insurances will be covering this. They are beginning to cover this in pilot programs. And why wouldn't they? Why wouldn't they? Because ultimately the data shows that it works. It's less invasive, it's less risky. And as far as insurances are concerned, it's far less expensive than doing surgery. And once insurances fully realize that, then they'll get on board. Up until then, no, it's a cash in the barrelhead business. How it works in my clinic. I'm a medical doctor. I'm not a used car salesman, and we don't ever want to be accused of twisting arms. So you come in, if I think you're a good candidate, I'll explain to you, this is what I think should be done in your joint, whatever. I tell you, I will send you a proposal, and that will break down everything I discuss with you in the clinic that I need to do. And along with that is an associated cost with a bottom line figure. And you get to view that at home. You get to consider it. I encourage you to call me. Most people have questions. We can jump back on a Zoom, or you come back into the office. We can discuss it, answer all your questions, because you have to be comfortable. There's no point of sale pressure in my office. Again, for medical doctors. We're not trying to sell widgets. I hope that answers your question. Can this procedure be used for lumbar spine injuries, bulging discs, arthritis starting? Absolutely, it can. And it just so happens that because of my fellowship, I was trained in spine. So I am one of the few docs in the area, certainly, if not across the country, that treats almost every joint in the body. You know, because I do neck and back, I can treat all of the joints of your neck and back. I can treat, in addition to your knee joint, your hip joint, your shoulder joint, your elbow, hand, foot, ankle joints. And it works very well. We tend to hit home runs off of patients with chronic back pain and discogenic disease. We go right into the discs with bone marrow. We do what's called a 360 treatment, where we're treating not just the disc, but the joints at that level, and most importantly, all the ligaments at that level to get more support. Because quite often, a lot of back pain is just instability with aging, with injuries over time, and with just poor genetics. We tighten up the ligaments and get more support, and you work hard in physical therapy and get a tighter midsection, we can solve a lot of back pain. So yes, the answer is yes, we treat spine as well. Who else? Is it okay to have maintenance shots every couple years? Absolutely it is. And, you know, the true believers in my practice do come back to me for at the first sign of you know, other injuries that they developed. And I have, you know, patients who come back periodically for treatment in the same joint. Yes. So that's not a bad idea. I had a total, this is from an anonymous attendee. I had a total ACL and both meniscal tears. I had knee reconstruction after a couple of years. It's okay. Would this help me? Absolutely, it will help you. One of the things that's done that occurs after such a major reconstruction is that you are left with a residual sort of instability. So it's a very smart thing to do is go back and inject that cadaveric tendon repair, to also inject the collateral ligaments, to inject the patellar and quadricep tendons, the patellofemoral ligaments, medially and laterally, as well as, you know, bathe the remaining cartilage that you have and the remaining meniscus that you have with your repair cells. So this is a smart thing to do. So absolutely, we treat following surgery. In fact, I would say a fair portion of my practice is post-surgical pain patients. Another anonymous question. Do you harvest blood cells on one visit and inject at another? No, we do not. We harvest the cells in the morning. We inject them by noon or just after noon. That's how that works. Can this help SI joint pain? Absolutely it can, but I got to tell you, SI joint pain, true SI joint pain, very small part of my practice, very small part. And I say that with confidence because I'm the guy who actually sticks a needle into the SI joint and proves that that's where your pain is coming from. SI joint is usually part of and SI joint pain, by the way, comes usually only after injury, stepping in a hole, falling through a ceiling, that kind of thing. Or it comes with age. It's also prominent in folks who just have, you know, bilateral back pain. It's killing me, doc. I can't get off the couch. We'll treat their lower lumbar facet joints. We'll treat the bilateral SI joints. And quite often we hit home runs doing that. But yes, absolutely, we treat the SI joint. And when I say treat the SI joint, I don't mean just injecting cells into the joint. That's the least of what we do. We inject the long and the short sacroiliac ligaments. That's important because remember, any joint that is painful is potentially unstable. And quite often it's instability which is causing your pain. So if we can tighten up the ligaments that connect the bones, we can reduce instability, reduce pain symptoms. Yes, we treat the SI joint. We do it routinely. Would these treatments be an option for SI joint instability? Yes, I hope I just answered that. How does the foraminal stenosis respond to this procedure? Very well. Very well. I speak personally. I suffer from a right 05 ridic. About 3 years ago, I was thinking, man, I'm going to have to find a spine surgeon to help me here. I had 3 epidural steroid injections because I'm entitled to those, and I did them. And they worked about the way I know they work. The first one worked best, lasted about 2.5 months. Second one didn't work nearly as long. Third one didn't work at all. I finally called up a colleague in New Jersey. I went over, I had my own platelets injected across the foramen. I was great at 1 month. I thought, that's great. Let's do this again. I went back for a second, 4 weeks later. I haven't looked back. I haven't had another epidural. Do I still have symptoms? Yeah, sure. I still have symptoms. I can tell it's there, particularly if I sit too long. But I'm not thinking about surgery anymore. And when it gets bad again, I'm going to go have another platelet injection. So yes, we treat that. What can we do to get insurance coverage for our sake and their profitability? Well, you could begin to harangue them, I guess. How come you're not paying for my PRP injection? That always helps. And if, if tens of thousands of patients are doing this, they might finally, pay attention a bit. There's literature out there they can look at, but the assumption is every commercial insurance company has a large board of emeritus orthopedic surgeons that advise them. And the majority of these people are still saying, oh, the verdict is out there. There's not enough evidence. Don't pay for that. Because they also know that it's beginning to encroach upon the prerogatives of orthopedic surgeons. And, they don't like that. There's a lot of hostility there. So there's still resistance. But I do think that it's coming in time. The question is how long a time? We just don't know. Can't answer that. Occipital neuralgia. Yes, we bathe the nerve with a form of platelets called platelet lysate. And that's very helpful for a nerve that is chronically causing pain, as in occipital neuralgia. So yes, we treat that by repeated injections of platelet lysate. We generally do at least 2 or 3 treatments and then stop and then wait. If you can't tell me, 4 to 8 weeks after that, I've done that you're better, I'll probably tell you, hey, it's probably not going to work. But yes, we do treat that. Any other questions? I think I've answered every one that I have here. I really appreciate the questions. I really appreciate your time once again. This is a subject about which I'm sure you can tell I'm quite passionate. I love what I do. When I compare it to what I used to do, I'm a much happier doctor. Questions from anybody else? Thank you very much. I appreciate it. Have a good night, everybody. Stay warm.